Dockable is about a technology company. We're about enabling technologies to support community care. Community care is done by you guys. All we do is provide things that support that. I have to say that telehealth doesn't do the job for you. It is there to help you. Today I'm going to talk about our work on risk stratification and how that you can use that information to identify your needs and then identify interventions that you can work on that. So risk stratification, we call it Artemis. Artemis is a Greek name for hunting, finding patients. And what that consists of is we take a range of data in from Surrey. So we've been commissioned by Surrey to develop the risk stratification. We pull in SUS data, we pull in primary care data from the GP practices, and a range of other data pulls into a warehouse that we support. From there, that data is then put through a risk stratification engine. We're agnostic on the particular risk stratification engine that's used, but in Surrey we use the combined predictive model that does a load of clever mathematics and thinking and generates a thing called a risk score, which is what the likelihood of an admission into hospital is, and a range of information around that risk score. We then take that risk score and we link it in with that data we pulled in already, and we have a processing engine that allows us to pull together a whole range of dashboards that allow clinical teams, business managers to drill down and identify the needs and the costs and the utilisation of all your patients across Surrey. That's available across Surrey. And Christine is here, will introduce herself in a while just to say she's a contact point. If you're a clinician here, GP, you wish to have access to the system, it's through NHS Surrey that you go through for that. Okay, so it's a web-based long-term condition dashboard, which means if you've got a web access and you've got the secure password, you can log into the data and you can view the data. You can drill down to CCG level, you can drill down to GP level, and you can identify all your patients and where they are on that risk score. And we'll see some pictures about that in a minute. You can filter down by disease groups if you want just COPD or COPD and heart failure. Who are they? Where are they? How much are they costing us? What else we got there? So we can also look at predicted costs because it predicts costs in the future, but it also gives you a history of costs, which now we can start doing some benefits realisation work, put an intervention in, has it worked a year later? Is the risk score changing? Because outside of a randomised control trial, that's all we have to tell. It's the nearest we've got to information about that. So what that does, it identifies needs and works out what needs we have across the community. And the things we're adding in now is allow you to do some intelligent management of patients. So we're adding medicine optimization in, where we look at polypharmacy and the effects of multiple disease drugs on people. Condition-specific optimization, drilling down to specific conditions. Intervention assignment, we can start recording interventions on it and what we're doing. And the regular refresh means that you can go from month to month or quarter to quarter and seeing changes in risk score as they run. So you can see, has this intervention worked? Is it doing a change? So that's important as well. So just to give you, that's one of the outputs that come out of it. But the interesting thing is the numbers, because when you look at telehealth, what do I pay for? How much have I got to afford? How much is this intervention going to cost? How much is it going to save me? And this gives you a really interesting picture of your patients across Surrey. And you'll notice right at the tip of the triangle, your very high-risk patients. The number of patients, which is along this line here, 602. Now these numbers change as we record this information and as patients change through the system. But you see, not a big number, really, across the whole 1.2 million population or what we've got. High risk, 4,000. And then you come down to low risk, 729,000. The interesting thing is those people in that low risk cost 243 million, while the people with very high risk patients, that we tend to focus on all the time, have cost 6 million. If we can do a 1% change into £243 million, we can save a lot of money. And what is those things? A lot of them are just A&E or their day cases or their outpatients appointments. If we could just adjust some of that with some technology and do some questions that you'd ask in the outpatients, maybe they don't need to go to outpatients every 6 months. Maybe they go once a year. We can use telehealth and technologies to communicate with people in order to reduce some of those as well. So what we identify here is need, and then we need to look at abilities. What abilities does someone have? Are they very IT literate or are they not IT literate? So trying to drill down to where people are on the social demographic position, how able are they to use technology? Because that also is a decision maker of what technology you put in place. You don't put the same bit of kit in every patient's house with the same need. You can have different levels of technology. I'll highlight that a little bit in a minute. But it gives you a flavour. The interesting thing is you know, the average cost here is £333. The average cost here £10,000. So the technology you put in can only, value-wise, can only be about 5% of that. So if you're looking to sell things into this market, you have to understand how much you've got to position a cost for. The other things it allows you to do is business case scenarios. You can put in how much your intervention is going to cost, and you can say what percentage in reductions you aim to get. And it allows you to identify, for your business cases, the savings you want to aim to get. That allows you to put a stick in the ground. This is what we're going to save. I'm just have to canter through these, I'm afraid. Prevalence of disease, benchmark. So here we can look between EasyDoc and Medlink and compare numbers of patients, asthma per 1,000, COPD per 1,000. Allows you to drill down to those things. Only give you a flavour at the moment. Understanding utilisation over time. If you select a range of patients within certain risk scores, what you can then drill down to is individual patients. So I'll anonymise this, don't worry. And then you can look over the last 3 years, what has their activity been? And you move the mouse over each one of those little activities. It looks a bit like a DNA chart, and it probably is something like that. And you can see what the admission was for, how long they went in for. Did they have an appointment with no outcome? Did they need to go for that appointment? If there's no medication change. If all you did said, are you checking your feet? Are you eating fruit and veg? Yeah, okay, come see me in 6 months. Do they need to be seen in 6 months? Yeah? We can change that a bit, change that £243 million. So a very flexible tool out there for you to use. And when we link that to telehealth, what it means is we can actually, I've coined this phrase, need-ability. Need and ability. And you can start positioning whatever type of technology you want, depending on people's need and ability. So very poorly symptomatic, IT illiterate, to very IT literate, where it's just an email with a website on that you can go to. And then we can start putting self-management programs in that allow us, based on patients' activation and how activated they are to be involved in their own care, we can start putting self-help information down. Patients can get an email every day with a web link in, and that allows them to go to a web link and answer their questions, be supported by self-care. Appropriate self-care, not just repetitive statements, but self-care that says, if I'm in Barnsley, saying no fat is have more mushy peas and less chips when you go to the chip shop. That's self-care. For someone who's very activated, I can say, you've got to reduce less fat, Adrian, and to me that means less donuts, less Krispy Kreme, yeah? It depends how activated I am, depends how useful that self-care is, and we have to make sure the self-care is delivered. So telehealth allows you, there's a range of equipment you'll see from a range of vendors next door. You can see across the range of, you can put specific technology in, and you can have different technology all for the same level of need. So someone can have a risk score of 85, but you may put some complex technology for someone who can't use IT at all, an elderly patient who just can't use it, or you just put scheduled emails for those who can. Same risk score, same need, but different interventions based on that person's ability to manage their care. And there's a range of stuff about telehealth there. So a range of options, like Charles has said, dependent on the ability of the patient. Tablets, iPhones, or whatever, all suitable there. Then the final thing is how does this fix with telehealth, telecare? Because obviously there's a telecare service running in Surrey around the various providers. How can we link some of this information together? We'll never get one big system, will we? We won't be one happy, interoperable band of care delivery people, will we? It's even more fragmented now. So let's not try and blow up that. Let's try and work with what we've got. So you have telecare on the left-hand side, and the example there is a TimeTech device that links for a phone line to a community alarm system, and then the community alarm team have access, and how they normally do emergencies. Telehealth is on the right-hand side. We're all within the clinical domain. And what we need to think about is how we link those two together at suitable points, and not necessarily move data all the time or move everyone to this big one happy team, but move information. So if there's been a fall, how do we make sure the nurse on a telehealth system can see that a patient's had a fall? That's where we need to try and link in. And that's doable, very doable. And as a company, Docabo, are talking with people like John Tech, Novalarm, to link that information across. So alerts and things like activity data can be pulled out of a TimeTech device and presented to the clinical team. So a range of interesting interoperable stuff there as we're trying to meet the needs of your patients in the home.
Yeah. I'm Christine Ratcliffe and I'm the Associate Director for IT Programmes at NHS Surrey, and I think I probably was the PCT champion for a while. And we made a strategic decision once partnerships funding was available that it was something that we could actually go out to procure, a risk stratification tool. So that was made in the summer last year. We went out to procurement and we chose to work with Docabo. And we have been working collaboratively with them and with, to begin with a GP champion, Dr. Peter Stott from Medlinks, which is part of the Dean's CCG. So that worked really, really well because we had a GP clinical champion as well, which provided assurance to a manager to say, yes, this is actually what is needed. So we've done that. We went live in December for the first time with Medlinks, and they tested it, which was good. Very, very pleased. Lots of tweaking, lots of sort of niggly little problems, and we have developed exceedingly tough and robust IG processes for the GPs and the clinician. Well, for the GPs, this has patient identifiable information. It is sacrosanct, but nobody else has that. I can't get to it. Docabo can't get to it. The data, the developers can't get to it. The GPs and their staff, if they give them access, can. So the GPs are the gatekeepers to patient identifiable information, and they allow access to the community nurses. So we have community nurses and GPs using it. We have a project manager, Trevor Johnson, who has been working. I can't tell you how hard he's been working to get this in. We have 61 practices out of 132 who have signed up using the system. We're working with the other CCGs. EasyDoc are starting a project on long-term conditions in the Birchwood practice, and we are talking to the other CCGs that haven't sort of implemented it yet. We're hoping within the next few months that the whole of the GPs will have access. But it has been paid for Surrey for the 1 year. What are we doing? The other part about this project is it's very much a pull project. This isn't, absolutely no way, the PCT saying, you must do this, you must have this. It's the CCG saying, this is what we need to actually manage our long-term conditions patients. This is a tool that we can use. So it's about them coming to us saying, can we have it? And us enabling that to happen. Trevor's been doing a lot with Tracy Weller, the data quality facilitator lead in primary care, doing lots of training, lots of work to actually tell people about this project, what it means, what it can do. And what I would say now, what we're doing is we're actually, all of the work that they've done, we've been listening to all of the users saying, could we tweak it this way? Can we tweak it that way? It would be lovely if it could do this. We want some more long-term conditions. Can we have them? Yeah. And we've got some enhancements coming through which will give more long-term conditions to support the dashboards. We're looking, as Adrian said, on medicines management, optimisation. Somebody's got a high BP, but are they on medication? That sort of stuff, to start to see those gaps. And also to manage the virtual ward. That was the biggest one that we've been asked for. So we've got a virtual ward. We want to manage those patients on it. Well, I think that's it from me.
Okay, thank you. Yeah.